Good afternoon and welcome to HIT Policy Update, a webinar tweet chat combo from healthsystemcio.com, sponsored by Lexmark. Just some housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemcio.com, and I will be your moderator today. We are holding a simultaneous tweet chat hosted by our Managing Editor and Director of Social Media, Kate Gamble. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can just view the tweet chat on the right-hand side of your screen in the Media Viewer panel. We'll also be using the Q&A panel. You can type in your questions at any time. Leave the default set to all panelists, and we'll take those later in the program. And you can download the deck by using the URL on your screen. It'll also be sent out in the chat box during the event. Just so you see how we're going to spend our time today, first we're going to go hear from our featured speaker, Dr. John Halamka, CIO at Beth Israel Deaconess Medical Center. Then we're going to hear from our sponsor represented by Mark Ostendorf, Director of Healthcare Sales with Lexmark Enterprise Software. Then we're going to have our Q&A with Dr. Halamka. So without further delay, I'm going to turn it over to our good friend, Dr. John Halamka.
Well, thanks very much, Anthony, and always look forward to these opportunities to share my life experience with all of you because every day as the CIO of 450 healthcare locations, I live the dream, meaningful use, MACRA, MIPS, IPPS, and so I've been there and done that, and hopefully my experience is valuable to you. And Anthony, the most exciting thing that happened today is I got my iPhone 7. So I now have a phone without an earphone jack. It's amazing. Oh, well. Remember, they took away products and they cost more. I don't get it. Okay, so on to our policy update. Today what we're going to cover is a bit about 2016, 17, and 18. What is it you're going to need from a product standpoint? What do we expect MACRA and MIPS is going to do? What is it that we can expect as there is an election? And regardless of Democrat or Republican being elected, there will be change. What can you do to prepare for whatever that change will be? And I'll speculate on where that might go. I mean, obviously, the first two agenda items will be factual, and the third, speculation. I think all of us in IT have watched the federal government's activities over the last 6 months and recognize that many, those who are political appointees, are trying to wrap up their legacy. And so they have said, well, yes, there's the Meaningful Use program going from 2 to 3, there's MACRA and MIPS, there's quality changes. And you see quite frequently that as these folks try to wrap up their legacy, that they have changed the trajectory of some of our policy programs. They've changed the time frame. They've changed the criteria of some of the policy programs. So it can be quite confusing. And so not a day goes by where I don't get an email something like this. Well, in 2016, is it a year-long reporting period or a 90-day reporting period for meaningful use? Now, I have software that was certified for the 2014 edition. Can I use that in 2016, yes or no? And these can be very confusing topics. So, Anthony, what I did in preparation for today is I spoke to all the folks at CMS who wrote all these regulations. And what I have, and I hope it's accurate, is a statement for everybody on the webinar as to what CMS believes are the currently enforced regulations and requirements. And then, of course, they can't share with me speculation on what will happen in the next few weeks, but certainly looking at the draft regulations and looking at the work in progress, I have a sense of what we'll see in the next couple of weeks, so I'll report on that too. So let's start. So we recognize the challenge with the Meaningful Use program is that in our various previous stages, people started at different levels of sophistication. Maybe they didn't have an EHR or an EHR that was crude, and maybe they didn't start the first year, they started the second year. Maybe they're a Medicaid rather than Medicare participant, and so they really had to invest and build, and they weren't measured for meaningful use immediately. So what that means is as we entered 2016, people were on different timelines and different trajectories, and it was all very confusing. So here on this slide, and I hope, again, this is going to help you all, is the definitive statement from CMS as to what it is you will actually need for all government programs related to electronic health records in 2016, 17, and 18. So that means what's left of the meaningful use program, an attestation to avoid penalties, what's needed for the inpatient prospective payment system, IPPS, what's going to be needed in theory for MACRA and MIPS. So there are two certification rules, the 2014 edition and the 2015 edition. And I know this is a bit confusing, but what ONC wanted to do was decouple meaningful use timeframes from certification timeframes. So they don't really talk about them as stage 1 and stage 2. They talk about them as the 2014 edition, 2015 edition. Each of those rules contains specific requirements for EHRs to have functionality, interoperability, and they have been rigorously tested by a testing lab to follow those criteria. If you look at what's called the CHAPL, the Certified Healthcare Product List online, you can find your exact EHR and its exact certifications. It's interesting because many vendors, although they're working on 2015 certification, haven't yet done 2015 certification. Again, a lot of folks are saying, oh my, it's 2016, I'm running, maybe it's the last version the vendor came out with. Is that going to be good enough for submitting my quality measures? Is it going to be good enough for attesting to meaningful use? So here's the story. In 2016, you need a product that was certified to the 2014 edition. Now, if you happen to have one that's certified for the 2015 edition, that's of course fine, but you don't need to upgrade this year. So that's important. You know, a lot of folks panicking, wondering if they must do a forced upgrade to the latest and greatest or push their vendor to certify to that next level of sophistication. The answer is no. 2014 edition, totally fine. Beth Israel Deaconess, for example, has all of its self-built systems certified to the 2014 edition, and we will continue using those through 2016, no problem. Now, how about 2017? Well, again, same thing that CMS has said. You could use the 2014 edition or 2015 edition in the calendar year 2017 for attestation. It's only by the time we get to calendar year 2018 that you must move forward on the next edition of certification. So as you look at your next 2 years of planning, you probably will want to do a version level upgrade of your hospital information system or your EHR to get the latest and greatest certification. Now, of course, there is a possibility, and I can only speculate, that as the presidential election occurs, that some of these programs that are currently in flight might be changed by 2018. You know, could be. But my experience with administrative transitions, and I'll get to that in a few minutes, is there's usually a set of career employees that stay around, and therefore a lot of the programs and policies actually continue administration to administration, even with a party change. So I think we can be pretty comfortable that what is being said about 2016 and 17 certainly is going to be in force regardless of the outcome of the election. And the trajectory I'm seeing for things like moving us from fee-for-service to alternative payment models to bipartisan issues, probably these 2018 requirements of having an upgrade will stay in force too. So I guess I would be a little bit cautious. Don't need to do anything for the next year, year and a half, but banking on 2018 having complete and total policy changes, everything being eliminated is a little premature. So keep in your budget, keep in your planning the notion of needing to do an upgrade to a 2015 certified edition EHR by 2018. Now, here is a bit of a confusing issue, and the reason, Anthony, I would never create a slide with such small type, but the reason I did it is I copied and pasted the language that CMS sent me unmodified, because you need to read this to see it and understand it. Which is, although it's true that your EHR might be certified to 2014 or 2015, the nature of the quality measure computations themselves may change even in a certified 2014 or 2015 edition EHR. They may decide, certain numerators and denominators are calculated differently, etc. So here is what's confusing. But again, you got the language in front of you. You do not need to upgrade your EHR, that is the certification 2014 and 2015, as I described it, is in force for MACRA and MIPS and IPPS, the Inpatient Prospective Payment System, and Meaningful Use and everything else. However, if the quality measure computations are changed by CMS, you actually should be submitting the quality measures per whatever latest requirements CMS has. So wait a minute. You don't need to change your EHR via an upgrade that's certified, but you do need to change your quality measure computations if CMS should happen to change them. Confusing. You would sort of think that quality measures would stay constant in a certified edition of an EHR, but it turns out the evolution of quality measure computations and their numerators and denominators actually may change more frequently than the certification of the EHRs themselves. So just keep that in mind. The way Beth Israel Deaconess works is we submit all of our data from our EHRs to a third party, and that third party does the quality computations and submissions on our behalf. And so that means our EHR isn't actually doing the quality computation, a third party is. And so I've been working very closely with this third party to make sure the quality computations they do follow whatever current CMS guidance is in force for the addition, subtraction, and division in creating the quality measure itself. So just something to be aware of, and just keep in mind, your EHR or your third party or whoever you use or whatever service is employed should follow the latest CMS quality computation guidelines. We will see on or about November 1st. It could be a little earlier than that, but at least what I hear from CMS is November 1st of 2016, the final rule for MACRA and MIPS will be published. This is a little bit of speculation reading between the lines, but what I hear is in this set of final rules that come out on November 1st, that it will clarify that the reporting period for 2016 will be 90 days. Any 90-day period you choose for your attestation to meaningful use, your computational quality measures, etc. And that's, of course, welcome news to us all, because you may have made changes to your EHR during the year. You may have had people come on for a period of time that wasn't a full year. So being able to choose any 90-day period in calendar year 2016 for reporting is something certainly AMA, AHA, and many folks in IT would like. So that's all good. Hasn't been adjudicated yet, but remember, all of us who provided input to CMS in their notices of proposed rulemaking really said that a 90-day period would be appropriate. CMS is really listening, so I think highly, highly likely that November 1st you'll see that clarification. Similarly, although the MACRA and MIPS rule of the notice of proposed rulemaking included a variety of meaningful use stage 3 targets, metrics for performance, a lot of them were quite hard. And so remember what happened. We originally with stage 2 of meaningful use said we need 5% of all of our patients to interact with the portal, looking up their labs, sending secure email, and interacting with their doctors electronically. And we found that in practice, especially in regions where PHRs weren't that popular or communities weren't that wired, it was pretty hard to get 5%. So CMS revised it down from 5% to 1 patient. If 1 patient looks up their data, if 1 patient sends you a secure message, that is sufficient for attestation. And then when Stage 3 came out, they said, and 35% of patients should have electronic educational materials, 25% should interact electronically, 10% should look up their lab results. Wait a minute, we couldn't achieve 5%, and now we're at 35, 25, and 10? How's that going to work? So I think, again, what you're going to see in the November 1st final rule is that the thresholds are going to be brought back down to more meaningful use Stage 2 kinds of thresholds. 1 patient does this, small percentages rather than these very aggressive percentages. And they will eliminate, of course, some of the things that are considered topped out in meaningful use Stage 2, such as the use of decision support or provider order entry. You won't even need to attest to that anymore because such a high percentage of docs and hospitals hit those thresholds in Stage 2, they'll just be retired for Stage 3. So fewer requirements, probably 9 or so requirements, lower thresholds, 90-day reporting period. My guess is as well, they'll also, rather than be highly prescriptive about quality measures, give you a pool of quality measures. And, Anthony, here's an example. As you know, I have no privacy, and I've signed away all of my rights to share my medical record, my genome, and my stem cells years ago. I have glaucoma. My ophthalmologist under meaningful use has been ranked on smoking, counseling, and blood pressure management. That doesn't sound quite right if the issue is my sight. Wouldn't it be better to judge an ophthalmologist based on my visual acuity and the maintenance of reasonably low pressures in my eyes over time, my visual field, or something like that? So I think what you'll see is this pool of quality measures where you can choose the quality metric that's most appropriate to your practice or most appropriate to the quality improvement efforts that you have been working on. Also, I think you'll see, and Andy Slavitt signaled this in his blog of a few weeks ago, some flexible implementation options for this next stage of regulation. And what do I mean by flexible implementation options? So I've included, Anthony, this URL to the blog from the administrator of CMS, Andy Slavitt. And in that blog, what you'll see is he outlines a couple of different approaches. You could decide as MACRA becomes effective with a measurement period of 2017 and really becomes effective in 2018, just to test your EHR. Submit a couple of quality measures. See if it works. And in his blog, what he highlights is that if you even just test and verify that, yes, you're preparing for this future of alternative payment models, they will not penalize you. So remember, with any of these federal government programs, there's carrot and stick. Potentially more payment one issue, but penalties and penalty avoidance certainly another. So test. Maybe that's what you want to do. And then you'll avoid penalties, and that's okay. You might choose to participate for just a small portion of a calendar year in 2017, getting ready for 2018. And if you do, you might be able to increase your income, but not by a large amount. It'll be some sort of small increase. You might choose to participate for a full calendar year in 2017 in MACRA and MIPS, in which case you might be able to get a more substantial payment. Or you might choose one of the risk-sharing programs, the so-called Advanced Alternative Payment Model, and one of the MSSP Managed Shared Savings Programs in 2017, in which case then none of the penalties will apply. You know, you'll be at risk, and these risk contracts may give you some upside gain. So again, realize that's a little bit confusing, but in Andy Slavitt's blog, in effect, what he said is, we get it. There are some organizations that are very well resourced and some that have advanced technology, and those may very well choose to jump in with both feet. Others that aren't prepared, don't have resources, don't have the current technology. They want to move slow, and that's okay. So in effect, what he said is, MACRA and MIPS is going to be, in some ways, design it the way you want it to be. Eventually, you're going to have to do it, but you might have a multi-year stage implementation rather than just jumping right in 2017 in preparation for a 2018 effective date. So take a look at Andy Slavitt's blog. Now, Anthony, this is where I get highly speculative.
Nice.
I actually couldn't watch the debate because, you know, I've been told that maybe one way to get through the debate is to take a shot of some alcoholic beverage, you know, every time, say, one of the candidates says something outlandish, but my liver couldn't take that. You know, I'm 54. So I read the debate summary in the New York Times, and luckily my blood pressure stayed even. The presidential election, I think, is certainly, as you watch the polls, very unclear, right? I mean, every day that goes by, what you see, it's becoming a bit more ambiguous. So you have to ask the question, whether we go Democrat, Republican, Libertarian, or Green, who knows? But what will happen is that on January 20th of 2017, all current political appointees will resign. And so that means the head of CMS, the head of ONC, they're all going to resign. Doesn't matter if we go Democrat to Democrat, they still all resign. So that means on the 21st of January, the people who will be left will be acting interims, and it may take 6 months or more to get somebody into those positions confirmed. So what might you see? In the next 16 weeks, you know, all of those folks currently appointed will wrap up their legacies and then be ready to prepare their resignation letters and depart from Washington. At ONC, although Vendel Washington, who replaced Karen DeSalvo, a very good person and presumably would want to serve in a Democratic administration if a Democratic administration is elected, will have to resign. And if you look at ONC today, the principal National Coordinator Deputy is John White. He came from AHRQ. He is a career appointee, not a political appointee. So again, political appointees gone, career appointees still there. So I imagine John White will serve as our national coordinator on an interim basis until that Republican or Democratic administration appoints a full-time national coordinator. And John, very thoughtful person, very sound thinker, very, very unlikely to radically change the direction that we're on. So presumably ONC will continue on the trajectory it is on, even though Vendel would depart. With CMS, the people who are working on MACRA and MIPS are all career appointees. Kate Goodrich and Grace Im, they're all going to be there on January 21st, and they are all going to move forward with implementation of MACRA and MIPS as it is finalized on November 1st, 2016. So again, I think you're going to see some real continuity there, and you'll be pretty confident that whatever we see in November will actually go forward through implementation in 2017 into 18. And I also think in general, and you know, Anthony, you never want to debate politics. You always get in trouble when you do that. But I would say payment reform, the idea that we are paying too much for health care, not getting the quality or outcomes that we want, is a bipartisan issue. As I am in Washington, I hear from senators and Congress people that we need to enhance functionality and quality measurement and interoperability, and this is really, it's bipartisan and apolitical. So as I think the next administration, whoever it is, will continue highlighting such things as reducing clinician burden, enhancing usability, enhancing data sharing and quality measurement, and paying for outcomes and quality rather than paying for quantity or more visits. All of that will persist, and I certainly talk to clinicians across the country, and they are all feeling completely overwhelmed by the collection of regulations that we've seen over the last 5 years or so. In fact, I was looking at some data yesterday. It was really quite striking. It was an analytics company took an audit trail of a large physician group and analyzed keystrokes over a 24-hour clock, and it went something like this. Doctors get up 6 in the morning, check their email, then begin their EHR work at 7. Every 15 minutes from 7 to 5, they're clicking on a keyboard with a different patient context, writing notes, entering problem lists, reconciling medications, ensuring quality is achieved, making eye contact, never committing malpractice, being empathetic. And I can tell you, as I talk to lots of primary care physicians, seeing a different patient every 15 minutes and doing everything that's necessary is near impossible. Then at the end of the day, they go home, have dinner with their spouse, put the kids to bed, and at 7:30, the clicks start again. They begin entering more structured data and more notes and meeting more quality measures and making sure they never commit a compliance violation, keeping the data private. And about midnight, they log off for the day, only to begin the process again a few hours later. The folks at IHI, Don Berwick and the gang, say often, sometimes our healthcare system engineers a solution that gets the result we designed. And in fact, over the last 20 years that I've been a CIO, 300,000 new pages of healthcare regulations have been added to the Federal Register. And one hopes that as we see the next couple of years, we step back and ask what we've done to ourselves if 40% of physicians in the country want to quit the profession because we have created such a collective burden. So we'll see. I can tell you CMS is listening, ONC is listening. We have a change of administration coming, and I think MACRA and MIPS will take into account the frustration that clinicians have felt, hopefully give flexibility to reduce burden, and hopefully the next couple of years will give you choice so that you can implement quality metrics and improvement as you wish, and hopefully be paid for working at the top of your license as opposed to being a data entry clerk. So finally then, let me turn it over to you, Anthony, and we'll hear from our Lexmark colleagues and then look forward to your questions.
Very good. All right. Now we are going to hear from Mark Ostendorf, Regional VP Healthcare Enterprise Software with Lexmark Healthcare. So Mark, you have the floor, and thanks for sponsoring the event today.
Absolutely. Thank you, Anthony. We certainly appreciate the opportunity just to take a couple of short minutes to speak with you and your audience regarding who Lexmark Healthcare is and who we intend to become. Lexmark Healthcare has grown quite rapidly and dynamically over the past few years, both via organic growth as well as through acquisition. And I'm looking forward to sharing who we've become and ultimately our vision for the future. Before we get into that, I'd like to cover just a few accolades the company has received over the past couple of years. You can see that we were positioned as a leader in Gartner's 2015 Magic Quadrant for both ECM as well as Enterprise Search. We are the only vendor that has a top 3 best-in-class ranking for both VNA, Vendor Neutral Archive, as well as ECM, Enterprise Content Management. Over 50% of all U.S. hospitals use some level of Lexmark Healthcare solution. And in fact, over 3,000 hospitals worldwide use the Lexmark Healthcare solution, including over 220 of those that also use Epic. We've successfully migrated over 300 million imaging studies to date, and we are the #1 global independent VNA market leader. And perhaps most excitingly, We were the 2015 recipient of the Company of the Year by Frost & Sullivan. So you can really break down Lexmark Healthcare into 4 or 5 key buckets. The first 4 are exclusively designed to work with our software solutions, and those are the ones that I'll be covering today. The first core bucket is our VNA, or Vendor Neutral Archive, which is really the foundation or the backbone of many of our healthcare solutions. This is really just an agnostic way to store and manage DICOM images regardless of your PAC system. And by doing so, this would obviously and ultimately increase your control and ownership of those DICOM images throughout your facility. The second core bucket is our enterprise image connectivity solutions, which really offers a host of different solutions ranging from mobile capture, being able to capture those images and store either in an enterprise content management repository or wrapped in DICOM and stored inside of a VNA or your PAC system. It would include integrations with, say, scopes inside of an OR or in the GI lab, with further integration into an agnostic media writer or video editing box. And it also includes solutions such as CD burning. So it's really a host of different solutions, and you can see that over 50% of U.S. hospitals do use one of our enterprise image connectivity solutions today. The third core bucket we refer to as enterprise content management, or ECM, and this is really the area where we have traditionally focused. Furthermore, this particular bucket can be broken down into 2 distinct areas. The first one would be our back office solutions, so think accounts payable and the capture and management of invoices linked directly with an ERP, or such things as the management of your employee personnel file inside of your human resources department. On the other side of the house, we have a variety of clinical solutions, so the capture and management of medical records inside of HIM or at the point of registration, or those patient financial services documents, think 835s or paper EOBs, ultimately linked back to your EHR. And finally, the fourth core bucket is our enterprise viewer. This viewer is both referential and diagnostic viewing, and is the only truly zero footprint viewer on the market today. So you can see through these 4 key areas, we've created really a highly diversified portfolio of products and solutions, and we're a very different company than we were just a few short years ago. But what really does this all mean for a healthcare organization? Before, you may be in a position to have limited access for your clinicians. Perhaps they're stuck in department silos, or given access is controlled by a variety of independent applications. This creates both vendor lock and block, meaning you can't get access to the data that you need from a single point of contact. It also includes issues like forced migrations every 5, 8, or 15 years. With the implementation or introduction of a Lexmark healthcare solution, all of a sudden you've created a single point of access for all of your clinicians, typically within the EHR, as well as a consolidated storage focus, so a single repository for all of that information, which would certainly increase any risk to PHI exposure. So for more information, please visit us at our website or watch the YouTube video that you see on your screen. And of course, I'd be happy to answer any questions that you may have, and feel free to reach out to me directly. Thank you for your time today.
All right, Mark, thank you very much. Again, appreciate Lexmark's sponsorship in making this event possible, and appreciate your presentation. Now we have time for questions, and we've got a few in, so let's get right to them. If you have one, you want to send it into the Q&A box. Leave the default set to all panelists. All right, Dr. Halamka, first question. Can you comment on how CMS is looking at hardship cases? For example, we are moving from our Meditech platform to Epic, and concerned, without investments in the old platform, that we won't meet the threshold until we get to Epic.
So this is an excellent question, and again, I reflect that there are some very noble people at CMS. So for all that you might think that government can be faceless, The people at CMS working on these programs are real-world clinicians practicing a day or two a week, as well as regulation writers. So when I've met with them over the last 6 months and talked about hardship, they've said, please submit your hardship explanation because they feel your pain. And they are very, very likely to grant hardship exemptions. As we go from this transition to the Meaningful Use Program to MACRA and MIPS and fee-for-service to alternative payment models, there's going to be a lot of hardship along the way. A lot of the software is immature. A lot of people are switching out EHRs. They're doing mergers and acquisitions. So very, very likely, and of course I can't guarantee, but very, very likely CMS would grant such an exemption.
Yeah, you don't want somebody coming back to you and saying you promised.
But they're so reasonable. I mean, it's a wonderful era that we're in right now. We really have the A-team in charge of MACRA and MIPS at CMS.
All right, very good. Next question. My understanding for ECQM submission is that hospitals and clinicians must submit, assuming they are submitting and not attesting, with latest CQM definitions. Definitions released by CMS in 2015 for 2016, reporting using Cypress 3.0. Please confirm. Wow. Right,
and so that paragraph, you know, Anthony, one of the things I always joke about is, you know, I get 1,500 emails a day, and a typical email might be something like this. I'm a nurse practitioner in a federally qualified health center who works part-time as an anesthesiologist, but I work across 3 states with 2 different EHRs, and how do I attest to meaningful use?
Right.
And so often I go to my colleagues at CMS and say, help! So the person who asked that question of me today is exactly correct that this is the question and exactly why I put the paragraph from CMS in the slide, which says what this person asked. You must, even though you're using a 2014 certified EHR, which is totally cool, submit the quality metrics that are currently in force from CMS. So what that might mean is your vendor with a 2014 certified EHR gives you a patch for your quality measures so that they are consistent with the latest and greatest definitions from CMS. They don't need to recertify their software. That's not necessary. And that's, you know, it can take hundreds of hours to recertify software. So you completely understand why vendors are doing their very best but may not have got up to the 2015 certification level. So 2014, as long as the ECQMs are patched to match the current CMS requirements, totally fine.
So let's talk a little bit more about that. You had mentioned that one of the things CMS had been trying to do is to decouple meaningful use from certification. Now, I assume we think this is a good thing, but I'll let you comment on that. And then the subsequent question is that now it seems like they're decoupling ECQMs from certification, even though certification was sort of intended, or one of the points was to make sure the EHR could spit out the proper ECQMs, but now they're decoupling that, which doesn't seem to be a good thing. You're using this third-party company. This is just another added expense. Talk about that, please.
Okay, so Anthony has just raised very controversial points. And so we have to, I think, Anthony, be careful. What do I think and what do I say versus what does CMS think and CMS say? So here's my issue. The pace of technology in the private sector today is moving quite quickly. Did anyone envision when the certification rule was written that companies like Commonwealth, SureScripts, or Epic would offer novel kinds of interoperability? You know, did anyone forecast, you know, what kind of population health or care management solutions may be coming out of startup companies, or cool apps for your phone, or wearable technologies that enable patients to submit patient-generated healthcare data? None of those things were forecasted in the certification rule. So if what we say is every federal government program must hearken back to a set of certifications that were actually created in 2013, we will quash innovation. we will force buggy whip technology on folks who are driving cars. So far better would be for the government to say, you know, here's an outcome we want to achieve. Lower readmissions by 5%. Now, if you want to buy your 80-year-old patients Apple Watches, as Aetna has suggested, go for it, right? If you want to put bathroom scales that report weight through Bluetooth through your phone to your doctor for congestive heart failure patients, go for it. If you want to build, like Mercy has, a giant hospital of telemedicine and teleconsultation with no patients actually physically there, go for it. Achieve an outcome. Don't prescribe specific technology changes too fast. And one last factoid for you. I recognize, again, this is a bit controversial, but Anthony, I'm sure you're doing autopilot driving with your Tesla these days.
Yeah, on the way here today.
Oh,
right.
Yeah, of course, yeah. We know Google and Tesla and maybe Apple, who knows, all working on self-driving cars. And so when the Department of Transportation last week issued guidelines on self-driving cars, they didn't say how the software has to work or what technology you have to employ. Use radar, use ultrasound, use infrared. They didn't say anything like that. What they said is, here is the safety metric you need to achieve. You know, however you do it, don't care, as long as driving the car by these objective criteria is safe. So my argument to the folks working on the Meaningful Use program and MACRA and MIPS and future programs is, tell us the outcome you want to achieve. Don't be prescriptive about the technology. We'll achieve that outcome in ways that might be highly variable across regions in the United States. Now, as you say, you know, there is a flip side to this, and that is we talk about interoperability. If I say that an allergy is the substance you're allergic to, the reaction you had, the observer, the level of certainty, and a time date stamp, but another, say a vendor of EHR says, oh, just type in allergy to penicillin and you're done. Well, we do have a disconnect. So sure, I agree there should be some minimal certification on interoperability, like you would certify a thumb drive, right? When you go buy a thumb drive, you're pretty confident when you plug it into your computer, it's going to work. And that's because it has been certified to the thumb drive standard. It doesn't, in that standard, tell you it must be green or blue or red or square or oblong. It just says, here is the interoperability it needs to follow. So I guess my controversial view is skinny down certification to a bare set of interoperability measures that are objectively tested and otherwise focus the policy side of things on outcomes, not technology. And CMS, I think, is listening to that. I don't know. So we'll see November 1st. And the reason that CMS has already started a little bit of the decoupling is because they recognize that there is a pace of evolution in quality metrics that actually exceeds the pace of certification. So hence they're moving in two different rates.
So we think you think the decoupling removing anything, you want the certification to shrink instead of grow. Decoupling out the quality measures is one step of that shrinking of the certification of EHR's criteria. We have a 2015 version. I guess so we'll have a 2016 version of EMR certification criteria, and do you hope and think it may continue to shrink? Is that the idea?
I think there are probably two potential approaches going forward. One is, as you say, every year there is a set of guidance that is issued, and that guidance will help vendors choose. You know, if we're going to share summaries with allergies, oh, this is what the form of an allergy should be, and that's fine. The other way is to recognize that as we incent doctors and hospitals to achieve certain outcomes and quality, they will have incentives to share data like never before. And there is some aspect of customer-vendor relationships that the marketplace will make able to customers those functions and features which are going to make them happy. You know, so at very least, shrink the certification criteria, focus on a few interoperability measures, and presumably, you know, that can be updated yearly. The other option is set an outcome, incent that outcome, and let the market achieve the outcome.
Okay, very good. Let's talk a little bit more about this third-party company concept to create the ECQMs. If anybody could do this sort of in-house, I would imagine it's you, but you have chosen a third party. Is it absolutely impossible for a health system to crunch these numbers outside of the EHR but in-house?
And the answer is, of course you could do it yourself, but why? My philosophy, again, it's one of these things that you guys might find controversial. Buy what you can. Build what you must. And so the things we really focus on building are your unique mobile and cloud solutions that the marketplace hasn't quite matured yet. But if I can go to a third-party vendor and for maybe a couple $100,000, have them do 1,000 different data submissions to government agencies and private payers, and it's PQRS, IPPS, APM, name your acronym. My God, that frees up me to do exciting stuff. So we've chosen such an approach. It turns out to be very scalable, and if CMS changes the formula tomorrow, my third-party vendor changes it, I don't have to worry about it. Very good.
For any, and this last question, because we'll get going. Could it be possible that for some of these measures, when they do come out, there is some work required on your end because the front-end clinicians have to document or do some things differently in order for the third-party vendor to get the right data to spit it out properly?
And you are correct. Two ways to do that. One is to create structured data so that at every encounter you're capturing whatever is necessary for the quality metric. And I have argued to NQF and CMS and others, we should never design a quality measure that requires physicians to enter more data that would have not otherwise been captured as part of the encounter, right? So if you're doing problems in meds and allergies in labs, compute quality measures based on the stuff you're capturing already. The only other option, because I really don't want to add more structured data elements, too much physician burden, is to use such technologies as natural language processing so that the data elements are extracted from the note the physician writes or dictates. That's a technology in evolution, you know, not totally perfect, but certainly holds promise for reducing burden because physicians will be documenting and we can pull quality measures out of that documentation.
Very good. Well, that's about all for today. When we close out, just if you can take a moment to answer our post-event survey, we'd appreciate it. I want to thank our speakers, Dr. John Halamka and Mark Ostendorf, and I certainly want to thank Lexmark for sponsoring the event, so check out their website when you get a chance. You'll receive an email when this archive has been posted to our YouTube channel. For those of you who hold the CHIME CIO certification, attending our webinars gets you one CEU. Please let CHIME know you were here, and if you've asked us to do so, we will. Sponsorship opportunities, you can contact Nancy Wilcox, and if you need a certificate of attendance for another CEU program, you can use the final slide in this deck, and of course, go to our website to view our upcoming schedule. So once again, I want to thank Dr. Halamka, Mark Ostendorf, Lexmark, and our attendees. Everybody have a wonderful day.
Thank you.